Thank you, everyone, for giving me the opportunity to present. I have no disclosures, except that none of these cases, none of these complications are mine, of course. So, iliac artery injuries. So, before we talk about management, I think really the important thing is to talk about when they occur and how to identify those cases, because you need to be prepared, when it does occur. So, typically we see it after EVARs, TVARs, TAVRs, any sort of large bore arterial access. Anyone that has significant aortoiliac occlusive disease. So if you see a CAT scan that looks like this with a lot of calcium, small diseased vessels, you should kind of plan ahead, in a worst case scenario. And along the lines of small is all relative with this, right? If you're putting in a 20 French sheath, the 6 millimeter vessel is small. If you're putting in a 5 French sheath, then a 6 millimeter vessel may be enough. Typically, when I do these sorts of cases, I like to get a CTA if the creatinine is normal, which I think helps with planning and sizing as well. Okay, so what are the signs? So abdominal back pain and then an acute drop in the blood pressure, the most common signs that you should always be looking out for. So especially when you're treating the lesion, doing a balloon angioplasty, really keep a close eye on that blood pressure. And then other kind of intraoperative events dictate that as well. So if you just, deflated your balloon, that's, a common time where you may see a RP bleed or a removal of a large sheath. So in terms of management, these I think are the tenets of kind of what to do. So we'll go through them one by one. So first, of course, is resuscitation. So along with those lines is, make sure you have an active type and screen for these high-risk cases. Make sure you have blood products. Be ready to transfuse, because again, seconds to minutes matter here. And then clear communication if you're doing this in the operating room, with nursing, anesthesia is very important. Really, one of the first things you should do is consider kind of tamponading that area. So the most common time I think I see this is right after a balloon angioplasty of the calcified iliac. You deflate the balloon. And then you take a picture and you see extravasation. So the first thing you should do is, put your balloon back up and reinflate it. Along those lines, leave the balloon on the wire, because again, you have seconds here to really react to that, and make sure you take a picture after you do the angioplasty. So in terms of balloons, you can use the balloon that if you just deflated a balloon, you can use the same one. If it extends into the aorta, which I'll talk about in a bit, you may need a semi-compliant balloon, so like a Coda or Reliant. But keep in mind, those come on, require a 12 French sheath, and typically you'll need the contralateral access, 035 system. So in these challenging cases, that can be, another caveat. And I really think one of the mainstays of treatment for bleeding is really covered stenting for iliacs. So we thankfully have a bunch of good covered stents. My preference, and I think what works well, is a balloon expandable stent for the common iliac artery, because really you need to land that stent very precisely right at the origin of the vessel sometimes, and the balloon expandable will help you do that. And there's a couple on the market. And then for the external iliac, if you rupture there, sometimes I prefer self-expanding covered stents, so a Viabon is a good option. And then I think, as kind of we're alluding to throughout the conference and this morning, sizing is really key here, because you don't want to undersize, because obviously you're not going to seal the bleed or injury there, but you also don't want to oversize and then propagate your injury potentially proximal or distal to the stent. So this is where I think getting a preoperative CAT scan, if you can, will help you size that, so you can have those covered stents in the room and ready to go. IVUS is another good tool, as we talked about. Or if you already did a balloon angioplasty, you can kind of use that to kind of gauge your size. Other considerations after placing your stent are reversing the anticoagulation, getting postoperative imaging, and of course keeping your patient in a monitored setting afterwards. So everything I talked about was more about injuries in the iliac, but the other real caveat is you can have an injury that extends up into your aorta, especially if the injury is in the common iliac, in the proximal common iliac. And so these can be much more challenging to manage. One of the first things you should do, and I mentioned it now, but really just in general, is you should always ask for help, because having an extra set of hands will help you here. For this, you should consider, if you don't already have it, getting contralateral access, and this is where you can put up a large aortic occlusion balloon to kind of temporize the situation until you figure out what to do. So there's a lot of different ways that we treat the, distal aorta. So we've done kissing stents, but as you can see, one of the risks of that is you can have little kind of leaks, gutter leaks. So it's not really the best way to do it. And then there's some newer techniques with CRAB where you put in an aortic cuff, but again, that's more to treat the occlusive disease. And I think some of this, for aortic injuries just depends on, how your patient's doing. In a really emergent situation, like when we see rupture AAAs, we sometimes consider doing a aorto-uni-iliac procedure, which you see in the middle. We just put a long stent all the way down from below the renals into the iliac to kind of quickly seal off the hole, and then do a fem-fem and embolize the other side. There's also some, you can do like a standard aorta bifurcated graft. There's some that actually will sit on the bifurcation. So for aorto-iliac occlusive disease, sometimes I like to use an AFX because it's a lower profile device, and you can maintain your native aortic bifurcation. So I thought it would be a good idea to go through a case. So this is an 84-year-old who had a bilateral buttock and thigh claudication, less than a block, with a decreased femoral pulses. So pretty former smoker, kind of classic story. He had CKD, so I went straight for an angiogram after getting some non-invasives. And here you can see, very significant common external iliac artery disease with a lot of calcium in the external. So this is a case, where you should see this film and be prepared for kind of a worst case scenario for a rupture. So for this one, I used a shock wave, which, gave me a decent result after the lithotripsy. And then I went ahead and tried to post-dilate it with a little bigger balloon, which was probably my mistake there. And instead of going straight for a covered stent. And here, even though I didn't take good pictures, honestly, the scenario was, the blood pressure dropped and they started having left-sided pain. And then you can see the common iliac isn't really filling and it looks a little bit strange. So for this, the first thing I did was just reinflate my balloon, which kind of helped temporize the situation. So this was just the balloon I used before. And then I went straight for a covered stent, a VBX, which kind of sealed off the hole up here. And then I just placed another stent distally just to help. And then in the remaining time I have here, the other thing that I want to talk about was, in addition to bleeding, of course, you can also have occlusions. So when do those occur? So again, a large arterial sheath and injury from that, from inadequate anticoagulation. So maybe your sheath was occlusive in the artery and you weren't fully therapeutic on your heparin. Another common scenario is embolization. So if you have someone that has AFib, usually you can see a piece of clot that kind of typically sits right at the bifurcation of the iliacs or the femorals, and then any sort of trauma. The tenets of this, I think, are obviously make sure you're fully anticoagulated if you have an occlusion. I think you have to really determine what caused it to be able to figure out how to treat it. So if it's acute thrombus, then you're likely going to need to do a thrombectomy, whether that's endo or open, and then treating the, like I said, the underlying cause. The other thing to consider, especially for more, chronic situations, is, open surgery is always a consideration. So if you have a unilateral iliac artery occlusion, you can consider a femoral bypass or some sort of open surgery, depending on the issue. So here's another case. So there's an 82-year-old male who underwent a TEVAR via right femoral artery. And so as we were pulling the sheath back, we noticed that there was a loss of the right femoral artery pulse. So we did an angiogram, and then, if you see it, the sheath is up here, and then you see this little stasis of contrast here. So pretty classic for a dissection in the external iliac artery. So initially I placed a balloon to try to pop open the dissection, going up and over, which didn't really fully resolve it. So I ended up putting a covered stent, which as you can see, looks good after that. All right, thank you.